Good morning, everyone, and welcome. I want to thank Dr. Dippel for the breakfast symposium, and thanks Rector Nendix as well. So today's a really big day for us. Critical limb ischemia, limb salvage, wound care. This is really, really important. So hopefully we'll keep your attention all day today. And as you remember, tomorrow we have our pedal access cadaver course, which fits in very, very nicely with the session of below the knee and pedal access, which we're going to be getting into this afternoon. We have a little bit of a change in our schedule. Dr. McKenzie has to get on a flight, so we're going to have Dr. McKenzie go first and talk about atherectomy and critical limb ischemia. What is the data, and is it worth the time and cost? Dr. McKenzie?
Thank you, Jaafer. Great meeting, and thank you for including me in it. Today is an opportunity to look at kind of what we can do with some of the technology, both new and a little bit older, and how effective it is. These are my disclosures. And currently available atherectomy devices, we have several different types of ways of debulking the artery. And from the conversations yesterday, I think we're realizing more and more that you just don't want to leave the atheroma behind and push it out of the way and potentially injure the external elastic lamina and the internal elastic lamina. And so the different technologies we have include catheters that will have a directional atherectomy where you can cut towards the atheroma. You have a rotational atherectomy device that will spin around a central axis and debulk in a 360 type of region. You have orbital atherectomies that start gaining and work very well in some of the calcific lesions. And then you have a ablative atherectomy, as you see with the laser. So each one has their relative strengths and some weaknesses as you go through it. And that's something we have to kind of help decide what type of atherectomy device you're going to use once you've decided to do an atherectomy. This is what we're concerned about. When we do an angioplasty, we think it's a nice, gentle remolding and reshaping of the artery. Well, it's a controlled disruption or dissection. And a lot of times when you can actually see a disruption of the internal and the external elastic lamina. And here's the dissection flap that's created with it. Not only that, and you saw in some of the earlier slides that Eric was showing, that once you have that injury, the body responds. And here you can see where you've had some disruption of the internal elastic lamina in the media, and that's where you see the most pronounced intimal hyperplastic response and cellular response. So when we do an angioplasty, we also injure the artery, and the artery is going to respond. So the idea is, what else can we do to try and avoid injuring the artery? In the early 20th century, we started looking at atherectomy when I was at New York Presbyterian, and we presented on the first 579 consecutive patients that we did with a directional atherectomy device from 2004 to 2007. This was actually presented at the American Surgical and then written up in the Journal of Surgery. It was for claudicant and limb-threatening ischemia. Exclusion was acute ischemia and iliac lesions because they were contraindicated. We had the data, the angiographic outcomes, and follow-up all reviewed by a dedicated research team independent of the primary operators. This is what we saw coming out, and again, I'm going to be focusing on the tibial area, but we had the vast 218 of these lesions that we studied were in the tibial region, and looking at those patients with critical limb ischemia, and again, a high percentage of TASC-D type of lesions. And we looked at it to get to the bottom line. Claudicants, we found that they did very well for limb salvage at 100%. Secondary patency was greater than 80%, going out to 2.5 years, and primary patency around 60%. For those patients with limb-threatening ischemia, we saw about an 80% limb salvage. So again, is it worth it? I would challenge you, yes, because you can save 80% of the limbs going out to 2.5 years. Secondary patency was in the 65% range, and we had about a 40% primary patency. So again, there is progression of disease as you go out long term, but I think the most important thing of is it worth it is we were able to save limbs. This really brought the question of what is the prospective way of looking at this data. And I was fortunate enough to be one of the co-global PIs for definitive LE. This was a study looking at the standalone effect of Silverhawk and TurboHawk atherectomy devices for the treatment of femoral popliteal and tibial perineal trunk disease. 800 patients were included, 47 sites globally. We had an independent duplex and angiographic core lab evaluating all outcomes and all results, and a clinical events committee that arbitrated and adjudicated any adverse events. Inclusion criteria included Ruther-Becker 1 through 6. Asymptomatic patients weren't included. Had to have greater than 50% stenosis with symptoms. Lesion lengths up to 20 centimeters. And you could have multiple lesions. So you could have a 15-centimeter lesion and then another 10-centimeter lesions. As long as there's an intervening segment, both those lesions could be included in the trial. Reference vessel diameter between 1.5 and 7 millimeters in diameter. Severe calcification was excluded because we had definitive calcium as a separate study. We had in-stent restenosis was contraindicated by the IFU, even though most of us did a lot of in-stent restenosis. And of course, if there's an aneurysm, there's really no need to do an atherectomy. How did the patient distribution work out? We had about 600 patients, or 599 patients that were claudicants, and 201 patients that were critical limb ischemia, with the vast majority of those patients with critical limb ischemia having tissue loss, and over half of them being Ruther-Becker 5, 10% Ruther-Becker 6, and about a third being Ruther-Becker 4 with rest pain. The adjunctive treatment, we found that predilatation was necessary in about 9% of the cases in order to pass the atherectomy device through the lesion. And generally that was a angioplasty balloon of 2 millimeters to just allow passage of the atherectomy device itself. Post-atherectomy touch-up balloon angioplasty was occurred in a third of the patients, and of that, 50% met inclusion criteria saying that they actually did not need it, but it was the user's preference to do touch-up balloon angioplasty. And of the 800 patients, we only had a 3% bailout stent rate. What were the complications peri-procedurally? We've always heard concerned about embolization. We saw a 3.8% incidence of embolization. And we took a lot of time discussing how we define embolization. Basically what we said was anything that reported any type of embolization, whether the user saw it, whether the core lab saw it, whether the CEC picked it up, anything that we saw in embolization, we counted it. And then of that, we had 2.1% of those patients did not require intervention. So only emboli requiring intervention was 1.5%, and the vast majority of that was treated with aspiration and removal of the emboli. Dissection was 2.3%, and about 1% of that did not require intervention. Again, if they did have a dissection, majority of it was stented, and that's where the majority of the stents came from, that and perforation. The perforation included wire perforation, atherectomy perforation, or balloon angio perforation. Any perforation was included. The overall complication rate was a 7.6% for any complication. So how did the patients do? Again, is it worth it? And what we found is that we had a significant improvement in Ruther-Becker classification, ankle brachial index, quality of life, walking, speed of walking, stair climbing, and the overall generalized question of quality of life. We saw an immediate improvement in 30 days, and that was sustained out to 1 year. So we saw a significant improvement in patients all the way after intervention and carried out long term. So what was the result? For the claudicants, what we found, we had 473 lesions in the 598 patients. Mean lesion length was 7.5 because we had some multiple lesions, some short, some long. If you look at the longest lesion per patient, it was in about the 8.4 range. Baseline stenosis was 72 or 73%. And this is where we had one issue. The primary endpoint was a peak systolic velocity ratio less than or equal to 3.5. And we found we had an 82% primary patency and freedom from reintervention rate. So if someone got reintervened on and still had no residual stenosis, they still counted as a failure because they had to have a reintervention. When we lowered it as a secondary endpoint to a peak systolic velocity of 2.4, because when we originally set up the protocol, we didn't know 2.4 was really the better number, we found it was 78%. So the vast majority of the patients did well, and those that had an elevated velocity got treated anyway. So the number I'd encourage you to take home with you is a patency rate of 78% at 1 year by duplex ultrasound. If you look at the difference between diabetics and non-diabetics, we see a lot of patients that, if they have one type of procedure, you always say, and the diabetics do worse. Well, what we found with the atherectomy, that's not the case. We had a 78% primary patency and a separate determined, prospectively monitored group and subgroup analysis for claudication, and we found with the diabetics and the non-diabetics, they did exactly the same. So that's important. You look at patients with CLI, since a lot of patients with diabetes has CLI. Lesion length, the infrapopliteal, we had a 90% patency for intervention below the knee. So I think atherectomy is a tremendous advantage to use when you're dealing with below the knee lesions. 75 to 77% for the SFA and popliteal. And these were all reasonable lesions. 5.5 centimeter mean lesion length in the infrapopliteal segment. If you look at patency for length themselves, the longer lesions did not do quite as well as the shorter lesions. So the lesions less than 10 centimeters and CLI had about an 83 to 81% patency at 1 year. 67% patency in the longer lesions greater than 10 centimeter, and the mean lesion length was about 14.5 centimeters in that long segment group. And we had over 200 patients in that, or 200 lesions in that group. If you look at the CLI characteristics, again, we had mean lesion length of 7.2, 76%, and a 30% CTO group. So again, CLI, as you'd expect, chronic total occlusions, and multiple lesions, tandem lesions involving SFA, popliteal, and tibial lesions was not unexpected. And here we go, looking at primary patency as a secondary endpoint, and basically we saw that we had a 71% primary patency using peak systolic velocity less than or equal to 2.4, and 279 lesions, 201 patients, and then 76% baseline stenosis. 95% limb salvage at 1 year in those patients with critical limb ischemia, and 2/3 of those patients having tissue loss. So a fairly significant long-term result of limb salvage. Secondary patency of 88%, and primary patency of 71%, as mentioned. And wound healing, basically we saw that, again, 95% limb salvage. The wound healing was at 3 months, over half the wounds were healed. At 6 months, 2/3 of the patients were healed, and about 72% at 1 year had healed wounds that remained healed. So in conclusion, I think atherectomy is a safe and effective tool to have in your toolbox. It's well worth the added effort to do, especially when you do it in a safe way. And I think going slow, packing frequently is important when you're using a directional atherectomy. And also it's important to realize each atherectomy device has its own strengths and weaknesses, and you need to know the strengths and weaknesses of each one as you decide what type of atherectomy to do. I thank you for your attention. I look forward to any questions.
Thank you very much. Thank you, Jim. So I'm going to turn the stage over to Dr. Alan Block, a good friend of mine, a podiatrist. He's going to set the tone for today, and honestly the tone for what we've been seeing over the past several days for CVC, which is you have to use a multidisciplinary approach, no matter if you're doing AAAs, limb salvage, wound care, whatever you do, especially in the field of limb salvage, because I promise you, if you don't work with your podiatrist, if you don't work with your wound care centers, you're not going to be able to save limbs. Dr. Alan Block is a podiatrist and gives some excellent talks. Probably will have some inappropriate slides, so if you're offended, please turn away at that time. Alan.
Oh, thank you. Nice introduction. All right, so good morning. So let me start off by telling you this. There is a two-door system, and the problem we're having right now, and what I've found in a lot, is that patients who are sent to a particular doctor, if they go in the group in one door or the other door, and they can be right next to each other, is the difference from them walking out or being hospitalized and maybe losing a leg. It's that simple. And you know, the thing about it is we've got pedal access now, we have other things that have gone on. We now open all the vessels below the leg, and I say we, because I think I'm part of a team, I've never opened a vessel. But here's the fun thing about it. If you don't have the right people in line to take care of these patients don't get better, and they become a malignancy. They die. They become a malignancy to their family. So I got to tell you something, the two-door theory does exist, and I'll tell you very simply, what has happened is the bar in my house, the bar in my office, in my patients, I treat them like they're my family, because I want the patient back, and I want a patient that I can do something with. More importantly, when you take a look, you have to realize this is not a standalone disease. Thank you. We have diabetes, and if you look, and I'm going to go run through this, but every 7 seconds someone dies from diabetes, and every 17 seconds someone is diagnosed with it, and every 20 seconds a leg is amputated. That is down from 30 seconds to 20 seconds in the past 10 years. That's 4,320 legs taken a day, and that's kind of scary when you take a look at it, because somewhere, somehow, 6 degrees of separation, that's going to be someone in your family. But I got to tell you, my biggest thing is I have screened my patients now, and here's my thing. I don't have the time, nor do I have the ability or the heart to treat a patient who doesn't want to get better. I can't do it anymore because I won't bury a patient. It's not what I'm going to do. And I look at them and I go, why didn't you wait? Because critical limb ischemia is the last thing we should be seeing in my office. That should be an emergency, right? This has been going on for quite a bit of time. And when I get that patient, they look at me and they go, Doc, I know that once you start cutting, you don't stop. That is a patient you really have to educate, and you have to spend time, and they need psychological training as well. And so does the doctor for wanting to treat them possibly, because you have to change the patient load that you're taking care of. More importantly, we have 185,000 amputations happening in the United States a year, and if you look at that and you find out the number one reason a diabetic is put in the hospital is for a diabetic foot infection, usually an ulcer. And if you look at 11% of the healthcare dollars now being spent on diabetic foot care, and again, we also find out that 85% of the patients who have an amputation of the leg or foot usually preceded by having an ulcer. So if you look below knee amputations, if you look here, 5 to 8% of those patients die in the hospital within the first 30 days. And if you go higher, above knee amputation, 8 to 12% will die. And you can do the numbers just as well as I can. If you take a look, unfortunately, these numbers have gotten worse, not better, in the past 12 years. And less than 20% of the patients get an angiogram. The latest study I saw was 2012. It said 16%. Only 50% of the patients get an ankle brachial index before having an amputation. Now, I have to tell you, as a professional, I take it very serious, and that's this. Those patients deserve options. That's where they come to you. An amputation, while an option, should not be the first. And if that's the attitude and that's the kind of treatment we're giving to our patients, we're not doing the right things, because amputation never is the conservative option. When you take a look at it, you find out that almost 9% of the population of the United States is now type 2 diabetic, or diabetic period. And 7% of the population of China is type 2 diabetic. And if you take a look again, 5% of the population of India is now type 2 diabetic. 1 in 400 children living in the United States now are not only obese, they are type 1 diabetic. They are developing non-cirrhotic liver tumors at such a large rate. The CDC tells us by the time these children reach the age of 35 years of age, we'll have to do 5 times the liver transplants. Now, Michelangelo, as you well know, Michelangelo did the beautiful statue of David. He came over here, lived on the American diet. And unfortunately, this is becoming the world diet. This is what's happening. We're getting heavier, we're getting bigger, we're getting slower, we're not moving as well. We're starting to see the complications of a longer life with an unhealthy attitude. So very, very simply, how do you treat society? You know, you come up with the technology, and what you do is you treat the pathology, but you must change the psychology of not just the patient, but the treating physicians. Because it's easy to send that patient to the doctor and go on and know that doctor's doing the right thing. But it's not always how it works. And education, dissemination of information, which we've seen happen in breast cancer, right? They took a pink ribbon, they named a race after it. Breast cancer is the best funded cancer in the world. More people die of cardiovascular disease and peripheral arterial disease than all the cancers combined. Yet we are not shouting on the street corners about it. And very, very simply, that's what we do. We keep education, like meetings like this. This is how you change life, right? So very, very simply, if we go on from it, this is that patient load that we see over age 65. By the way, 85 and plus, the largest growing population in the United States. Diabetics, 12 years longer sustaining. Kidney disease, and I'm going to put another thing in there, transplant patients. These are patients, when you look at them, they've had that accumulation of life. And this disease state has been going on for a long time, but they're not aware of what's happening. And this is a patient load we have to worry about. When you look at claudication, a patient who comes in who's a claudicant, how many of those people in a year will from claudication to critical limb ischemia? And the answer is about 3 to 7%. Most conservative papers say 3%. If you take this batch of patients here, again, renal disease, diabetic, over the age of 65, they have claudication. The chance of them going from claudication to critical limb ischemia climbs to as high as 37%. So the thing about this is, when I would send patients in and they tell me, the standard tells me, my patients are not standard patients. You cannot standardize a patient who has a disease state. You cannot align patients like that. And if we keep thought processes up like that, we'll never get ahead of this disease. If you take a look, an ABI of 1 is normal. If it's below 1 or above 1, you have a patient who is in trouble. And the question is, when are you going to intervene on that patient? And it could be medical intervention, but you have to make the patient aware. If you look at calcium in the body, 1.1 is not indicative that patient has calcium, nor is 1.2, but 1.3 is. And why that's important is, when I get to send the interventional now, I go, I have great concerns this patient has calcium. So that doctor has the right tools to treat my patient. Critical limb ischemia. By the way, the first two go together, because this is that patient who went from claudication to critical limb ischemia. What happened is that blockage went from 70% to 100%. And the difference is, we could have intervened before it became critical limb ischemia, before we're trying every desperate act, and that's where we really need to be. Again, if that patient has diabetes, 12 years longer, with or without neuropathy, that patient is a calcium former, as well as calcium found in x-rays. Now, I want to show you, there's my podiatrist here. If you see calcium on the forefoot, you can see a vessel should not light up on x-ray. Only bone should light up on x-ray. And you know, again, they have a CAVI test now where they do the cardiac volume index instead of an ABI. And what they're testing is the elasticity of the vessels from the aorta down. And instead of just doing an ABI, which I think an ABI is fine, but I don't think it's enough, because when you fall asleep thinking you can feel a palpable pulse, you have to realize that a lot of times the microcirculation is not benefiting from that. Smoking, we won't even go into that. And again, your pre-op testing, when you look at creatinines and GFRs, you know if you see a creatinine over 1.7 or a GFR of less than 60, that patient is a calcium form, which is really important to let the doctor know what you're looking at, because this is a harder case, as we all know. Very, very simply, when you start to look at this, only 31% of wounds heal within probably 20 to 30 weeks. And you saw, Dr. McKenzie just showed you that even after they've opened up the vessels, some of these patients heal in 7 to 8 months later. And you have to realize that. But the fact is, we have 70% of the wounds that are not closing. 85% of the amputations I told you before are preceded by a foot ulcer. Number one reason a patient is put in the hospital who's diabetic is because of an ulcer on the foot. 80% of hospital admissions for diabetics are infected, and as I told you, half the size in 4 weeks. If that wound is not getting better in 4 weeks, then we have a problem, and the treatment option is not very good. Vanderbilt did a calcium study, and I thought it was really important because what they were trying to do is justify why these patients had amputations. What they came up with is more calcium. Where calcium is present, better chance for an amputation. And Dan Clear over at Cleveland Clinic then followed it up because they amputated 66 above-knee amputations. All these patients had angiograms about at least 6 months before the amputation. He went back looking for the answer why he couldn't save these legs. What they found out after they thawed these legs out, they couldn't re-angiogram because they couldn't get through. And they very, very simply couldn't IVUS them. So they ended up doing cut-downs on each one of these legs and found out these patients were full of calcium. So what happened is what they came up with is what Vanderbilt did, is calcium equals critical limb ischemia and amputation. We know the specific subset of patients, but I will tell you this. What bothers me the most is I see these wound care centers, and the last thing they're doing is send these patients for evaluation, for reevaluation, or opening them up and getting blood flow. What happens if we restore the blood flow? I guarantee you that number would not be 31%. Do I believe in hyperbaric oxygen? Absolutely. The skin substitutes and everything else we're throwing at these patients. But if we don't restore the flow, and I have to tell you something, the most exciting day was in 2006 when they said we're going below the knee block. We go from the knee to the ankle. And then all of a sudden, about 2 or 3 years ago, they started saying, we're going to go from the toe and we're going to go up. And pedal axis is really important. And you know, I got to tell you something. It has changed the way I can treat a patient. And every patient that I get to treat who gets better, 10 more show up to take his or her place. But I got to tell you something. When you hear restore the flow, and they're not doing that as probably the primary thing they need to do, I don't think we're doing right. And you know, they defend it with an algorithm. They tell me the algorithm doesn't fit that. Well, sure it does. And I'll tell you something. The worst day of my life is when I have to go in and tell a patient that I'm removing their leg. It's never something, they're always surprised. They don't care what stage they are and how bad they've taken care of themselves. They're always surprised and shocked when I tell them we're going to do an amputation. And I have to tell you something. Why does that chicken cross their own? Well, it's the same reason cancer patients will do any kind of test or take any kind of medication to save their lives. And I promise you, when you get to that dirty, dark road and you tell a patient they're going down that road to amputation, they get on board quick because they're afraid and they don't know where else to go. So the bottom line is this. I was watching 3 live cases one day with a group of 8 physicians from UCLA, vascular surgeons, very bright men. And they said to me, Block, there's not one case that we would have intervened on because our number one reason for intervention is pain. I said, that's interesting, because my number one complaint about my patients, they don't know they're in pain because they're neuropathic. You know, I got to tell you, that built a bridge that day. So when I do an ABI of a patient, I don't make it pretty. I just say, see that flat line? That's the heartbeat of your leg. When it's gone, your leg's gone. So I tell them. But I have to tell you what happened. I took 6 articles, 6, 2 from interventional cardiology, 2 from interventional radiology, and 2 from vascular surgery. And this is what they said. Open up one vessel below the knee, the patient can possibly heal. Open up that second one, the patient starts to resume a normal lifestyle. And open up 3, the patient will resume a normal lifestyle. And I'm that bad girlfriend. Give me 1 vessel, I want 2. Give me 2 vessels, I want 3. It's the way it works. And you know, when you give me 3, I'm going to say, do more. It's just the way it's going to work. But I will tell you, as a physician, as a medical care professional, we can no longer afford to be deaf to a patient who is mute. And I thank you.
For those of you who were in our Business of Medicine session yesterday afternoon, probably understand now and appreciate how important cost is going to be in the future, even today and in the future. And so I wanted Dr. Choksi to talk to us about limb salvage, saving limbs, lives, and money.
Good morning. Jaafer, thanks for inviting me, and Dr. Block, that was a very stirring talk, I must say. So it's very important for us to know our PAD as cardiologists, as internists, as endocrinologists, as podiatrists, because this is a very emerging problem, a true problem that's going to cost a lot of money to the exchequer. So if you look at 1995, there were about 12 million people who had PAD. Fast forward to 2010, 17 million, 2015, 19 million. So a lot of patients. If you look at diabetic patients above age 65, 30% prevalence of PAD, less than 65, about 15% presence of PAD. If you look at different disease processes, Alzheimer's, stroke, cancer, CAD, PAD is far more than any of these disease processes. As Dr. Block said, a lot more money is being poured into Alzheimer's awareness, CAD, cancer, research, cure, but not that much for PAD, not that much awareness. Even today, I have to beg endocrinologists to look at these things, diabetologists to look at the foot. It's a shame that we are doing a very poor job of, if you want to call it marketing, whatever one may want to call it, but create awareness for PAD. Now, interestingly, amputation was the first procedure in 67% of Medicare patients who underwent major amputation. In 2012, 20,000 patients, Medicare patients with CLI, major amputation was the first procedure. Majority of them did not have any revascularization, and half of them did not even have an angiogram. Now, we would think that this being the most educated society in the world, we would keep learning, but actually we have not, and as Dr. Block pointed out, actually these numbers are increasing instead of decreasing. So the probability of amputation depends upon who you are, where you live, minority race, lower socioeconomic status, age, sex, insurance payer, and of course, low hospital volume. If you end up in a hospital that doesn't do all these things, your leg will be gone. What's the missing link? It's angiography, and not angiography, but selective angiography. It becomes very important. ABI is important, but it'll miss things. But if you have symptoms, if the physical findings are highly suggestive, if somebody has critical limb ischemia, selective angiography is the way to go. It reveals generally that the disease is less severe, as suggested by a non-selective aortic leg runoff, CTA, MRA, and you can do something for these patients. Angiography is actually protective against major amputations, underutilized, highly underutilized in CLI. As you could see, only 27% of the patients had an angiogram. It reduces mortality. It reduces the odds of having a major amputation by 90%. But unfortunately, only 27% of these patients got angiogram. Mortality rates with amputation, high perioperative morbidity and mortality, high revision rates. AK and BK, above knee amputation, below knee amputation, the top 5 surgical procedures with highest perioperative mortality. AK 15 to 20%, BKA, below knee amputation, 5 to 10%. Infant inguinal bypass, 2 to 8%. Endovascular, 1 to 2%, I think is on the higher side usually in our practices, less than 1%. Complications with amputation, it's not a benign procedure. 20 to 27% will have major complications, 10 to 30% wound infection. The revision rates are high for above knee, below knee. DVT is a definite problem with amputation. These people are bedridden. Cardiac complications, sepsis, bleeding, renal failure. So it's certainly not without complications. The 6th most expensive surgery, macroeconomic cost is $10 billion just for the surgery part of it. Most of the costs are in-hospital costs, 45%. Outpatient follow-up, MD follow-up, about 20%. Nursing home costs, about 12 to 15%. Rehab, home health care, durable medical equipment is the rest of the cost. Now, Barsh et al. In 2012 very clearly showed 15-year study that amputation is less cost-effective than surgical bypass or endovascular revascularization. The greater charges are generated by higher rates of complications and revision rates with amputation. Wound infection alone is going to cost $19,000 to $42,000, DVT $14,000. So overall amputation costs about $10,000 more than endovascular treatment. Of course, the readmission rates are high with amputation. and length of stay is also quite high. In addition, there are hidden costs: patients' inability to work, patients' family, caregivers' inability to work, reduces productivity, emotionally is very costly. $300,000 or more lifetime income-related losses per caregiver. That's huge. Co-payments, deductibles, handrails, wheelchair ramps, transportation. Annual nursing home costs about $90,000 for a private room, $80,000 for a semi-private room. Wheelchair accessible van costs about $40,000. Minivan wheelchair conversions costs about $13,000 to $17,000. So a lot of costs, a lot of personal costs, emotional costs, social costs, financial costs. So in multiple ways, it is quite expensive. Outcomes post-amputation, about 20% or so are discharged home, rest will go to a nursing home. 60 to 80% are unable to walk. Of course, depression, high two-year mortality, 30 to 50%, contralateral limb amputation. At 100 days, only 45% of BKA patients are not healed. At 100 days, 24% of AKA patients are not healed. Chronic pain, phantom limb, reduced quality of life, chronic back pain because they're favoring one leg, skin problems in the stump, poor prosthetic fitting. So all these are issues with amputation. Whereas with endovascular revascularization, majority of the patients go home. 80% are walking, even at 2 years, 90% live independently. Two-year mortality is about 20% in this group of patients because they have other vascular problems. The intervention rates are high, but so what? So in conclusion, does leg amputation have a significant negative impact? Obviously, yes. Limb preservation efforts are effective and durable? Yes. Are limb preservation efforts higher risk than amputation? Clearly no. Are limb preservation efforts worthwhile? Yes. Even if there's not enough veins for bypass grafting, now we have endovascular treatment from above, from below, from the pedal access, from multiple other accesses, direct popliteal access. So the success rate is very high to preserve the limb. How about in frail and elderly patients? Even more so. Dr. Romy showed a case yesterday, a 93-year-old lady. He fixed her leg and the ulcer healed. So for frail old patients, definitely yes. So in conclusion, primary amputation is not cost-effective, misallocation of US healthcare dollars. Thus, revascularization saves limbs, saves lives, and saves a lot of dollars. Thank you.
Dr. Eric Scott on non-invasive testing.
Thank you, Dr. Golzar, for the opportunity to be here this morning. Good morning, everyone. For the next 10 minutes, I'm going to speak on non-invasive testing in patients with CLI, and admittedly, it's not a particularly flashy topic, but I actually told Dr. Golzar months ago that I wanted to give this talk because I think in the next 10 minutes or so, I can change the way you think about how we use non-invasive testing to evaluate patients with CLI, and in doing so, allow you to help more people in the context of these tests. And an ankle brachial index, segmental pressures and waveforms, and arterial duplex of a leg, not one of these tests has ever saved a limb alone by itself. But yet these are the tests that are at the forefront of the tools that we use to evaluate patients with vascular disease every day. And they have particular limitations, I think, in the setting of patients with critical limb ischemia. Take, for example, this patient here. This was a 78-year-old female who went to her podiatrist with an ingrown toenail of the right great toe. She had a simple resection of part of the nail. She comes back a week or two later with the expectation that it's healed, but it's not. There's a small wound. And a couple weeks go by, and she comes in, it's slightly larger. It's a little bit confusing because she has a palpable dorsalis pedis pulse. I know, I felt it myself. So an ABI is obtained, and it's 0.7, so it should heal, and some more time passes. And 3 to 4 months into this, when the toe starts to turn black, even the patient herself realizes there's not enough circulation for it to heal. And then she comes into my practice when it's clearly too late. So how do we get ourselves into this problem? It has to do with the way that we detect peripheral arterial disease. And I make 2 points here. And the first is that as you move down the arterial tree from the aorta into the foot, there are fewer and fewer tests available to us to detect the presence of disease. And the second problem is on the right of the screen. that I think these tests, as we use them to move down the leg, there's overall declining sensitivity for the detection of these disease. So these two problems affect us in critical limb ischemia. Why? Because patients with critical limb ischemia tend to have a concentration of distal disease. In this study from 50 consecutive VA patients with critical limb ischemia, documented either by these types of tests or formal angiography, they had a clear disposition to tibial peroneal disease, and even into the foot, as depicted on the right side of this graph. This is where patients have critical limb ischemia. This is really where it's born. So if we look at the ankle brachial index, and break it down a little bit more clearly, that 0.7, there's data beneath it. The raw data, the 0.7, comes from a pressure at the dorsalis pedis of 124, but the posterior tibial suggested a problem. Its pressure was 70. If you do the math, you get a pressure of 0.39. Perhaps if that patient had an ABI of 0.39 along the way, she would have been referred more quickly for vascular consultation. The ankle brachial index, quite frankly, can mask tibial disease. We know by convention, we take the highest pedal pressure, not the lowest. We take the highest, put it over the highest arm pressure, and that gives us an index. And that's a helpful convention in the setting of peripheral arterial disease without symptoms or in claudicants, but it's not particularly helpful in patients with critical limb ischemia. Sometimes it basically ignores the more distal diseased tibial artery, and that's misleading when you're trying to evaluate patients with critical limb ischemia. It can be misleading for you and I. It's particularly misleading for patients in the front line, primary care physicians, wound care nurses, podiatrists, who don't necessarily understand the ins and outs of all of our testing. I can show it to you in another way, and this is a little bit more clearly. Each of these are patients of mine who have a normal ankle brachial index. Normal suggests the absence of peripheral arterial disease, but you can tell by these angiograms of the ankle and the foot, not a one of these patients doesn't have peripheral arterial disease. In fact, they each have occlusion of 2 tibial pedal peroneal vessels and have single vessel runoff in each of these instances. This has been corroborated by recent evidence from the Cleveland Clinic that ABI is a poor predictor of tibial disease. In this review of consecutive patients with CLI, there was no correlation whatsoever between ankle brachial index and the number of patent runoff vessels. Another problem with the ankle brachial index that's been alluded to already this morning is that medial calcification can falsely elevate these pressures. So when you step on the fluoropedal and the vessels light up without any contrast at all, you know there's a problem. And finally, ankle brachial index alone, it reflects the perfusion to the ankle, not the foot. So in the case of this particular patient, this is her angiogram on the right, and in the proximal calf, the trifurcation is widely patent. But you can see in the mid-calf, the peroneal and posterior tibial arteries occlude, and then the crux of the problem is actually the pedal image, probably the most important image of all of this, because it really summarizes what this patient's problem is. Aside from the lateral tarsal artery, there isn't a named patent vessel in this foot, and it's going to be difficult without intervention to heal that toe. So can the ankle brachial index really lead us into a black hole? It can. I think its 3 key limitations are that it can hide isolated tibial disease, it's a measure of perfusion to the ankle and not the foot, and it can be falsely elevated. But let's move on. There are more things to look at. How about use of toe pressures in patients with the CLI? In this same paper from the Cleveland Clinic, there was little correlation, once again, between the toe brachial index on the y-axis and the number of patent vessels. Only patients with 3-vessel runoff trended to have a slightly higher toe brachial index. And then another way, I think, to more clearly depict the deficiencies, to go back to the VA depiction of patients with CLI, look at their ankle brachial indices. 78% of patients in this cohort were diabetic, and as expected, their ankle brachial indices were all over the place. But we'd like to use toe pressures because we think it gives us better information. But look where the spread of their toe pressures are. They're all over the place. And so I think if you're in an office and you're using rudimentary pressure measurements to determine whether a wound might heal or not, you'd use, let's say, an ankle brachial index of 0.5 And in these patients, you'd send half of the patients away thinking that they have sufficient circulation to heal when it wasn't true. And by the same token, you can use toe pressures of 30 to 50. And by this distribution, you would have potentially turned away 40 to 50% of these patients without any intervention based on their non-invasive testing. In other words, these tests sometimes allow us to, or cause us to make the wrong decision in the office to not pursue further vascular workup when it's actually what they most need. I'll make one other point about this too, and that is the most recent revision of the Lutonix below-knee drug-coated angioplasty trial was actually to throw out all of the hemodynamic inclusion and exclusion criteria for that trial, knowing that this is the kind of data that's out there, and for not wanting to miss a whole cohort of patients that really potentially are better served by being in the trial. So what about pulse volume recordings? This is a different modality to assess the vasculature. It's nice because its waveforms are independent of vessel compressibility, and it's a widely available test to use. But you have to remember that these results are region-specific. They're not vessel-specific, and so they can be confused by the presence of collaterals. And body habitus and edema can alter test results. Duplex ultrasound is another widely used modality. I use it a lot myself. I like it because it offers precise lesion location, and it also gives you both velocity and waveform data that can be particularly helpful. It's different ways of looking at flow, but it too has limitations. Quite frankly, some people don't have access to it at all. It's heavily operator dependent. It's time consuming to do these studies. One leg can take 20 to 30 minutes easily. And another limitation of it, quite frankly, it gets to distal disease. High-grade proximal problems on an arterial duplex can really mask or completely hide the presence of distal lesions, which is where problems are lurking for many of our patients with critical limb ischemia. And then to move on to more three-dimensional type imaging. CT angiography is probably no stranger to any of us in this room. It's a helpful modality to look at aortoiliac segments, femoral popliteal segments for sure, and it's a useful adjunct to plan endovascular procedures. But it too has limitations, particularly in critical limb ischemia. As Dr. Block has talked about the presence of, or the high prevalence of calcification in these patients, calcified lesions distort the imaging and make it difficult to discern the degree of disease on CT angiography. The presence of stents have a similar effect. And quite frankly, at least in my hometown, tibial imaging is sometimes quite suboptimal. When things don't light up, it's hard to tell if that's a timing problem of the study itself or whether it really reflects true tibial occlusive disease. And finally, a lot of these patients have renal insufficiency and can't get a CT angiogram for the large contrast load it takes to acquire these types of images. The alternative 3D modality is MR angiography. Its advantages are that it's unaffected by calcium, so it's potentially more useful in patients with diabetes. There are improving techniques for tibial visualization, but there are obviously limitations to this as well. It's very protocol and operator dependent. It cannot visualize through stents. It requires gadolinium contrast, again, a problem for patients with renal disease. It's a time-consuming test, and it's very expensive as well. To summarize these last three modalities, duplex ultrasound, CT, and MR, I searched peer-reviewed journals for the latest publications of data for the use of these modalities to detect tibial disease in patients with CLI. The sensitivities are in white, 93% for duplex ultrasound, 98% for CT angiography, and MR angiography with sensitivities for tibial disease of 84 to 94%. But I will make the point about this data, and that is, if you're an average center with average data, you don't publish it. This data is the best, represents, I think, probably the best of the best in terms of imaging modalities. When you and I go home and start working on Monday, often our labs aren't giving us these types of quality tests. There's always average, some above and some below. So I think you have to take these sensitivities with its context, knowing that we don't all have access to this degree of quality imaging. So to conclude, I want to leave you with 3 ways to avoid the black hole of CLI in your particular patients. And the first is to note the presence of tibial disease on ankle brachial indices studies. And if you're a reader of these studies, I mean that you can interpret this two ways, and I mean them both. First, if you're in your office evaluating these patients, look beyond the number, the ratio itself, and look at the raw data, the waveforms even behind the ankle brachial index, as a way to increase your detection of patients with tibial disease. And secondly, for all of us who read these vascular labs, ankle brachial indices in particular, in the setting of CLI as the indication for the test, I think it's really important for us to make note of it. An ankle brachial index of 1 with no comment on the occluded tibial vessel doesn't help anyone help their patient on the front line when it's not reported on the test. The second way to avoid it is to avoid using pressures alone to exclude the presence of peripheral arterial disease. There are numerous dangers to this. And finally, when in doubt, perform a selective angiogram to help figure it out. Thank you.
Excellent talk. Next is quality angiography for patients with critical limb ischemia. Dr. Iyengar.
Good morning. I'd like to say thank you to Dr. Golzar and the CVC faculty for allowing me to speak today. Today's topic is CLI angiography. A picture is worth 1,000 words. Folks, I want to let you know this is not going to be a statistically driven talk. Not many p-values for this. This is more common sense. And we'll go forward here and we'll go here. There's my disclosures. And the basics. When performing distal vessel angiography, contrast utilization becomes an issue. So you have to take into account the patient's baseline renal function, taking steps to avoid undue contrast exposure. And this was a statement that was hammered into my head during fellowship. It's pretty common, actually. Poor angiography leads to poor angioplasty. It's a really important statement because as an interventionalist or as an endovascular specialist, people tend to focus on the lesions. We tend to forget sometimes that if you don't show the lesion properly, you're going to lead with poor angioplasty. Renal issues. Dr. Walker will be coming up next to talk about CO2 angiography, so I'm going to leave that point out, but I will talk about some basic issues here. Treat the problem at hand, CLI, which is what we're talking about, not just a possible problem later, which may be acute renal failure. What does that mean? If I have a patient with a creatinine 2.8 who's coming in for an elective CLI procedure, I don't wait till that morning to say, you know what, maybe I should have hydrated this patient, or maybe I'll get that nephro consult afterwards. I bring him in the night before. I get that nephrology consult. I get the mucomystery. If they believe in it, or the IV hydration, I'll do whatever it takes before the procedure to avoid that potential catastrophe after. I've learned the hard way. You do a renal patient the day of, and you say, well, I'll try to minimize the contrast utilization, and maybe we'll avoid the contrast damage or exposure. Chances are you're going to get poor angiography, and again, that will lead to a poor result interventional-wise. So pre-admission is important. You can dilute the contrast miss, but again, only if adequate access to the lesion is possible, and I'm going to explain that further. Point of angiography. Oftentimes, the catheter placement in relation to the lesion is critical. Otherwise, you've wasted contrast, possible washout through collateral vessels, and undue radiation exposure. What does that mean? That means if you put your catheter of whatever choice it is up top by the iliacs and you run to the leg and you're looking for a CLI lesion, you might be losing all that contrast through collateralization or maybe not even seeing the lesion. So it's important that your catheter placement is optimal to the lesion in perspective, whatever you're going for. So the placement. This is a still image of a catheter in the right common iliac with no digital subtraction imaging. Don't see anything, do you? You see a little bit of the AT coming in there, but that's about it. This is basically a washout. It's a worthless shot, and it's a waste of contrast. When you place the catheter in distal right SFA under DSA imaging, much more robust imaging. So again, it's imperative that you do not try to take one shot does it all type mentality, but rather place the catheter in the proper aspect. Now, again with catheter placement, we've just discussed critical to have a catheter close to the area in question. Normally, people in their normal cath labs would have DSA versus conventional angiography. Movement needs to be controlled if you're going to use DSA. Every time a patient moves with DSA, as we all know, the image is worthless. Multiple lesions can also inhibit visualization. Movement. This is basically a patient who, as you see the little artifactual changes, was moving the leg just at the point of injection. Cannot tell anything about the popliteal vessel that's present. You can't see anything in the infrapopliteal vessels. Here is where the movement has been stopped. And now you can clearly tell that one vessel that's going below the popliteal artery. It gives you a much better aspect of what's happening. This is a point, though, that I'd like to talk about a little bit here. I want you to challenge yourself in these types of cases. If a patient is moving, and now I come from Florida, and majority of our patients are 80 years old or above, and I'll tell you, they don't respond to Versed, fentanyl, Benadryl than some other patients' populations might. Sometimes they become very combative, very belligerent. It's not their fault, they're just responding to the medication. If you have a patient that's continuously moving, despite all your best efforts pharmaceutical-wise, you can switch to conventional angiography. But let me tell you something, even with conventional angiography and movement, you're still not gonna get the best angiographic results. I challenge you to take these patients that if you have the situation, to take them off the table. And the reason why is, I'll tell you right now, I'm much more comfortable going to a patient's family member, telling them due to procedural issues, we have to bring the patient back the next day with anesthesia support to do the procedure properly, rather than talking to the patient's family 5 hours later that I had a massive complication during the case, which I have gone through. So I'll tell you right now is, it may be inhibiting your schedule. You might have a lot of other things in plan, other cases, patients in the office. Better to be safe, treat the patient first, the lesion second. Sedation to be titrated, anesthesia support like we just mentioned. You can try to place a band across extremity, but oftentimes when you try to restrain someone who doesn't want to be restrained, they fight harder. You may have to switch to non-DSA imaging, like we said, conventional angiography. So DSA versus conventional. Here's conventional imaging, and here's DSA. Hence, you can see much more clear on the DSA imaging when the patient's not moving. Conventional, DSA. Once again, conventional and DSA. So again, I always tend to say, if you can get the patient to lay flat and be still, digital subtraction imaging is the gold standard for these patients in this point. So the pros, clear imaging without any bony artifact. The cons, obviously, are the patient movement, which distorts imaging, and no ability to pan the camera. Again, you often might have this situation as well. Injection timing for your DSA. Too soon, too late, you have washout. Look at this image here. Clearly, there's digital subtraction imaging utilized, but not good opacification. This is the perfect timing of the injection to see the vessels. Multiple lesions. Now, important to realize that multiple blockages may be contributing to the underlying ulceration. In claudicants, it may be possible to just repair the iliac or SFA disease. In CLI patients, however, it's important to improve both inflow and outflow. Now, again, as interventionalists or as a endovascular specialist in this field, we often tend to focus on the lesion, but I can't tell you how many films I've reviewed of individuals trying to fix a tight SFA or a popliteal and not realizing that there was significant inflow disease or there was poor runoff. It's essential that you define the entire vascular tree prior to making a complex intervention. Visualization of distal runoff is often hampered by inflow lesions. You need to place a catheter to inflow lesions to determine the severity of the outflow vessels. What I'm trying to say is, if you have an 80% iliac blockage and you're trying to visualize the infrapopliteal vessel, you're going to have to get that catheter past that lesion. It's essential that you get the good pacification with that type of situation. Repair the inflow first prior to repairing the outflow to minimize contrast radiation exposure. Some people would argue, well, if you have the catheter past the lesion, go ahead and repair it. But again, you'll waste contrast if you cannot visualize it properly. Prosthesis. Oftentimes, especially in Florida, we have our share of hip replacements and total knee replacements. Hip and knee prosthesis interfere with visualization. It interferes with both DSA and conventional angiography. Angulation and magnification are vital for correct lesion assessment. What that means is that when I've reviewed films from my colleagues, I've seen individuals not ever come out of one image, as in they'll stay AP for the entire length of the case. Angulate, LAO, RAO, take it down, go to higher magnification, cone in on the image, whatever. Take multiple injections if you have to, but you have to define the lesion. So here, you have someone with a total knee replacement. You can tell from the image on the left, there is definitely disease going into the popliteal, but on the right, you can see once I've coned in and angulated, there is actually a very tight stenosis right above the knee prosthesis. That lesion obviously is borderline 90, 95%. Then obviously once I've angulated and treated with a DEB, that's the result, but only because I was able to see the lesion properly with angulation. But even in this case, once I fixed that inflow lesion, you can see right there in the popliteal proper behind the prosthesis on the left, that narrowing of the vessel. that wasn't very well visualized before I had fixed that lesion. So again, it's so imperative to know that you're treating the entire vascular tree and not just one focal lesion. Angiography should be post-lesion, should be utilized not only to confirm true vessel placement, but also true runoff. Multiple microcatheters can be utilized safely and will help in the placement of guide wire or decide if further intervention is needed downstream. So once again, this is just showing you that once we have the catheter down to the lesion, we're imaging it. Once we have crossed the lesion, I see another lesion downstream right there in the perineal. So again, it's so imperative to not only treat the lesion in focus, but rather the entire tree of that artery. So at this point in time, these are just showing you images of basically going past the lesion and obviously repairing with balloon angioplasty. Conclusions: catheter placement is essential. DSA versus conventional angiography. Contrast quality for renal issues. Multiple tandem lesions obviously need to be addressed. Clearly, angulation for prosthesis. And again, I can't emphasize enough, full vessel visualization. Treat the patient, not the lesion. Thanks a lot. Appreciate it.
Dr. Walker on CO2 angiography and critical limb ischemia.
That was really a great talk, and everything that he mentioned applies to CO2 angiography. In my 32-year career, one of the epiphany moments in dealing with peripheral vascular patients was when I actually embraced the use of CO2. And there are a lot of reasons for that. Now, why should anyone ever consider using this? Well, to start with, we want to avoid contrast-induced nephropathy, which is defined as a rise in serum creatinine of greater than 0.5 milligrams per deciliter, or a rise of serum creatinine greater than 25% of baseline. We want to avoid severe allergic responses, particularly anaphylaxis. It is of lower viscosity, therefore we can image via smaller bore catheters or longer catheters. We can image with close tolerances, for instance, 6-French devices within 6-French sheaths. And it occasionally allows for visualization of critically stenotic grafts that appear totally occluded by iodinated contrast. Because of the viscosity, there can be no flow in the graft. And finally, it's less expensive. It's about 2 cents per cc versus $1 a cc. But more importantly are the indirect costs, those of longer stays for hydration or follow-up, of the medications that we use to try to avoid contrast-induced nephropathy, the need for dialysis, which is prohibitively expensive, and this list goes on and on. Now let's look at these. Contrast-induced nephropathy is the third most common cause of hospital-acquired acute renal failure. It dramatically increases mortality, morbidity, length of stay, and cost, and the average increased cost for CIN, not for dialysis, but for CIN, is $10,345 per patient in that hospital stay and $11,812 over that year. The only absolute prevention against contrast-induced nephropathy is to not give iodinated contrast. Now, this is from Roxana Moran, in which she looked at independent risk factors for contrast, and we certainly know old patients are more apt to have this. People with poor renal function are more apt to have contrast-induced nephropathy. If we give a lot of dye, they're more apt to have contrast-induced nephropathy. But I ask you to look at something. If a patient is hypotensive, or has had heart failure during this process, or is over age 75, or has even mild anemia or diabetes, there are integer scores associated with these. And these integer scores could easily reach 10, which puts you right at the cusp of being a high-risk patient for contrast-induced nephropathy in a patient who has a completely normal glomerular filtration rate, a completely normal BUN and creatinine. Therefore, there are many patients who are at risk of contrast-induced nephropathy, and we simply ignore this. And when we get into complex peripheral interventions, particularly patients with critical limb ischemia, this is even more important because these patients often have impaired renal function. They're usually diabetic. They're often sick. Mild anemia is common. They're usually aged. So you might imagine why this becomes so important. Now, if we look at Roxana Moran's scoring system and see the incidence of contrast-induced nephropathy, you can see that when you are at high risk, you have a very high risk of developing this, and a very high risk via her integer score puts you at really a very high risk of contrast-induced nephropathy. Now, if we look at these patients, unless you're high risk, you're unlikely to require acute dialysis. But the very high risk, it's actually about 1 in 8 patients that go on to actually require dialysis during the hospital stay. And this impacts mortality. There's an impact on mortality even in the low-risk group when we give contrast, if indeed we cause contrast-induced nephropathy. There's no doubt this is something we want to avoid. Now, this is a problem which is growing as we perform critical limb ischemia interventions. Why? Because diabetes is epidemic. We have more interventions being performed. There are far more complex interventions. Routinely now, in my peripheral vascular days, I'm doing 5 or 6 cases of pedal arch reconstruction, going from one pedal vessel through another via the foot to try to ensure a patent arch. We're dealing with older patients. We're taking away the barriers of who is indeed a candidate for intervention. Now, what about avoiding contrast allergy? Well, we have minor allergies all the way up to anaphylaxis. When we have these problems, we pre-medicate patients. There's profound patient apprehension. These patients are very frightened of what may happen, particularly if they've experienced prior anaphylaxis, and there is a real risk of mortality. So why CO2? Well, it's been extensively studied in angiography. It's produced endogenously at 200 to 250 cc's a minute. We have 120 liters of this stored in our soft tissues. You can see how it's transported to the lungs for excretion, but there is no risk of allergic response or of contrast-induced nephropathy. And even in patients with elevated PCO2s, there's never been shown to be a risk. Now, if we look at this, there's been a long history of gases used in imaging. But I ask you to skip down to 1971, when Hawkins noted the visualization of the celiac axis on cut films after inadvertent injection of air. And that was really where CO2 angiography was born. I have to confess ignorance. Until 2.5 years ago, I never used this. I thought it was expensive, difficult to do, gave crummy images. I had no reason in my mind that I should use this. I've totally changed, and this has become a vital part of my armamentarium. Now, the whole concept here is that X-ray travels more easily through gas, therefore the image is a negative of that created by iodinated contrast. There's less contrast, therefore motion severely impairs image quality. So everything you mentioned about no motion is even more important than this here. This is crucial. Now, characteristics of CO2 are important to understand. It's non-toxic, it's non-flammable, it's buoyant, it's compressible, it has profound low viscosity, and it's highly soluble, far more soluble than O2, which is far more soluble than nitrogen. It floats anterior, it doesn't mix with blood. It must displace the blood if we're going to get ideal images, and that sometimes can be problematic in large vessels. It may trap in abdominal aortic aneurysms, which can result in gut ischemia, particularly if very high doses are given, which used to be a problem when people were administering this drug, CO2 under compressed conditions where they were giving a lot of CO2. But there are ways to treat this. You may aspirate the air, or more importantly, just simply rotate the patient because it floats. Now, in looking at toxicity, Cho extensively studied this, and he showed a single dose of 1.6 cc's per kilogram, about 100 cc's as a single dose, had no hemodynamic effects at all, and it's totally cleared from the body, totally gone, within 30 to 60 seconds. So one can completely do this again and again. Optimizing CO2 images requires DSA imaging. It's crucial the patient not move. You should use in-hole catheters, which mitigate against bubble formation. You must do, and this is very crucial and something done wrong by most of us, you must use slow, low-pressure injections. Otherwise, you will distend the vessel and the patient may experience pain. You must rotate the patient or camera. If there's excessive bowel gas, it may get in the way. And if necessary, consider the use of glucagon. And you must recognize that gravity affects imaging. So particularly in critical limb ischemia, you may need to elevate the lower leg, which may be lower than the thigh early on. So you may want to put it on a pillow. And you may want to bring the catheter right above this site as you're doing the angiography. Seeger demonstrated very close correlation in peripheral arterial imaging, 92% when CO2 was used as the sole agent. But there's a second point of this I want you to all listen to, 100% when supplemented by small doses of iodinated contrast. So if you have a tough case, you can do 90% of your planning with this. And if you simply need a little better image at the end, you can get by with 10 or 15 cc's of contrast versus 150 or 200. I think this is crucial. Positives, no renal toxicity, no dose limitations, can image via longer and smaller bore catheters, less cost. Negatives also exist. More radiation, you must have CO2 settings on your equipment. Most systems don't allow for road mapping, DM does. Motion artifact dramatically limits imaging. Overlying gas may limit imaging. May be suboptimal in very large vessels. Image quality is slightly less crisp than iodinated contrast, and you can't use this in cerebral or coronary vessels in today's world. Now, Hawkins found that early on, these big tanks that people were rolling in the room really weren't so ideal. They were filled with carbonic acid. There was particulate matter, including rust. There was water. These patients often had pressure injections of the CO2. And it was a closed system that could limit contamination with other gases seemed to be appropriate. And along came this device, which is what I'm presently using, and it's really changed things. Unlike the old systems that required a really strong guy to roll in this big, unsterile bottle in a bag that you shook things down with, you now simply hook this up, and it's actually easier than hooking up standard angiographic material, and it limits, this system limits against the risk of a pressurized injection. Just to show you the images, this would be an abdominal aortogram. This would just show you the iliacs here, pretty typical images. A patient in whom we need to deal with this lesion in the common femoral. You can see we're across, we're taking images. We're going to treat this, we're going to balloon this. And you can see here dense calcium in this patient. We're going to balloon it. And then hopefully we're going to see an image. Here we go, and here's an image. And if you want to clean this image up, you can indeed follow that with other images. Another case, patient with a high-grade lesion here in the superficial femoral, severe renal insufficiency, stented, very nice outcome. And then finally, very dense calcium, true critical ischemia in this patient. We made the image, we treated it, you can see the dense calcium. We treated this, and in this patient, the final image is not clear enough because of the calcium to really be certain. It seemed better, flow was brisker, so we're going to actually inject some contrast. And you can see here we're getting by with 8 cc's of contrast instead of more. The epiphany moment for me was when a patient came to me, and I was his 13th stop. He had an ischemic ulcer on one foot, he had gangrenous toe on the other foot. His creatinine had gone down the tubes to where it was 5.5. No one would intervene. He said, "Doc, please help. Would you consider intervention?" And by the way, he'd had a history of anaphylaxis despite pre-medication. We put him in that morning, worked on both legs. I was getting ready to leave for China, discharged him that same day. Also, by the way, he only had one kidney, fixed a high-grade renal artery stenosis to his lone remaining kidney. When I saw him back in follow-up a month later, he had healed the ischemic ulcer, the gangrenous skin was sloughing, his creatinine had come back down to 1.5, and this was all done without a pre or post-admit. So this has changed my practice. There's no pre-admission for renal insufficiency, no pre-medication for allergy problems, and it's dramatically decreased the number of patients in whom I would not consider some intervention. I thank you for your attention.
Dr. Jenkins, on after an amputation, who survives and how long?
Hi. Good morning. Okay. first thing that I would like to talk about is after the amputation. It all depends upon what you're going into the amputation table with. A lot of people have to be assessed. It's a case-by-case basis. And a lot of times you have several comorbidities that are going into the process, and it means a lot when you have to deal with several different things. Lower extremity amputation is often a result of PAD. Of course, we know that an estimated 5 million adults a year over the age of 40. Increased age and smoking. Now, I know Dr. Block didn't want to talk about smoking, but in my practice, smoking is a huge, huge factor in all of our amputations. If you have a diabetic smoker who is on end-stage renal disease and you have a triple threat, and any smoking diabetic is on a course going down. And you always have to get a very good, excellent history. When someone tells you they smoke 5 cigarettes a day, that's 10. 1 pack a day is 2 packs. You always double it, and then you always have to catch them smoking. Some people actually will sit in a chair and tell you they don't smoke, and you can see the pack of cigarettes in their thing. Anyway, you have to look at all of these things, especially when you're you're treating a diabetic with renal disease. Now, this chart is very informative. What it tells us is that we're on a treadmill. We're like on a hamster wheel. The case of diabetes is going up. From 2010 to 2012, it was an increase in almost 5 million cases just in the American population alone. And then when we look at what ethnic groups are most affected by these uptrend of diabetes, and of course we have American Indians and Alaskan Natives, and the non-Hispanic blacks or the African Americans lead the group. And mainly you can probably say it's a more socioeconomic, the type of foods they eat, and I shouldn't say they eat, the type of foods that these ethnic entities like to imbibe. It is very important to look into the socioeconomic and the healthcare disparity type of situation for these certain types of ethnic origins. And when you look at that and you see that combined, you have almost 40% or 30% of people of American Indians and non-Hispanic blacks who are diabetic. And of course, a lot of it depends on obesity and childhood obesity and the increase in that. Okay, of the mentioned risk factors, of course, diabetes and renal insufficiency are 2 most important factors. And people with diabetics also are 77% of the amputation rate in the United States are diabetics. And then you have to always think about what other disease entities these diabetics have. A lot of diabetics have 3 or 4 different comorbidities. As I was stating before, you have end-stage renal disease, you have obesity, you have hyperlipidemia, you have a lot of problems. And of course, one of the gorillas in the room when you talk about risk factors for diabetics is, of course, neuropathy. Neuropathy is what probably has led a lot of diabetics to amputation in the first place. It starts as an ingrown toenail that they do not really feel. They keep on walking around with the ingrown toenail until it gets infected. Once it gets infected, then they show up at the doctor and they seek treatment for the infected ingrown toenail if they can find that treatment. One thing I did want to say is there are still like 10 states in America that do not have access to foot care by a podiatrist because of the rules of that state. It's a political thing, and a lot of the amputation rates in those states have increased, and I'm sure Dr. Block can talk about this also, and there is legislation now to try and remedy that, and it's mainly the Medicaid population. It's when the states run out of money, of course, one of the budgetary things they cut are dentistry and podiatry, and it has had negative effects on amputation. But we'll go on to amputation. Of course, the end-stage renal disease and diabetics is very prevalent. One of the other things we have to look into is also the contralateral limb of diabetics when they have amputations and they have bypass procedures in the contralateral limb. due to circulatory problems bilateral. I'm going to show you some charts in a second, but these are some of the, okay. Limb salvage versus amputation. Of course, we consider whether the part is gangrenous, can it be revascularized, the severity of any type of infection going on, the combination of the above, and of course, patient selection, because you have to have someone who is compliant. The vascular surgery classification, wound ischemia, and foot infection, those are some of the things they look at before whether they want to revascularize a limb. And then, of course, we go on to the ABI classifications, which are important, except for they do not consider the toe brachial, the toe indexes, and the toe pressures. And we'll talk about that in a second. Now, here are some of the charting as to how we're doing with amputations and who survives after amputation. The higher the ABI score, of course, the survival rate of the person is a lot less. The lower the ABI, the lower the ABI, the person has a better chance of surviving versus the 0.9 and 1. Anyway, occlusive results, in occlusive patients, the amputation risk and the risk of mortality after amputation is higher. Now, here's some charting on mortality in patients undergoing initial major and minor amputations. Of course, a major amputation would be the ankle and above. A minor amputation would be transmetatarsal amp or any kind of toe amputation. The mortality rate with diabetics versus non-diabetics, or initial minor amputations versus major amputations, you can see we're running at 50% on the major amputations, and we're still down around 40% on the minor amputations. And there's a lot of other risk factors that go into these charting that I think that you need to consider. You also need to consider the obesity factor, the lifestyle modification. After an amputation, you have to go through certain lifestyle modifications in order to ensure that you do not have further amputations and to ensure that you are not a mortality figure. Now, here are some other indications of contralateral limb amputations when you are diabetic versus non-diabetic, and whether or not you revascularize the other limb. We're still running at a 25% of contralateral limb amputation compared to non-diabetics. Now, this is a chart that I really like because it shows that even with the upswing of diabetes in America, we're still doing better. When you go from 1990 to 2010, you see that we have decreased on a lot of the mortality or incidence of problems among amputations, as in heart attack, stroke, kidney failure, other amputations. It has decreased significantly. So we are doing a much better job. Now, this is amputations versus age of the patient, and this is almost like a 15 to 20-year period. You can see that the risk factor of age in itself is leveling off. So in other words, the 75-year-olds are surviving just like the 65-year-olds or the 60-year-olds. Now, here's a couple of cases. I always tell my residents that you can actually walk into a room and look at a foot and tell whether that person is going to survive an amputation, at what level, and whether or not the patient can be revascularized. Now, looking at this particular patient, you can see the condition of the skin. You're going on an uphill battle. TMA was done on this patient. This particular patient, a toe amputation was performed, but you can see her skin is pretty good. And all of her problems started with an ingrown toenail. A neuropathic diabetic with an ingrown toenail continued to wear a shoe that was too small, and therefore it ended up infection of the digit that further went on to osteomyelitis of the distal phalanx. And she's only 38. And here again, this is, we were trying to drain the toe. Now here's a good example of gangrenous process. Once the gangrene has gotten this bad, there's probably no salvation for any of these toes, so you have to look at a midfoot or above amputation. And this was actually a transmetatarsal amputation that had to go further to a BKA because the transmet did not heal. And this is one of the reasons why lifestyle modification is important, because this particular person, even after the the toe amputation, she still went on to smoke over a pack of cigarettes a day, and she was actually seen leaving the hospital after her BK amputation smoking a cigarette. And this is another instance where we had to do a TMA. This person, you can see the quality of that ulceration is not good. It's very fibrotic. The skin is not that good. I think Dr. Golzar did a revasc on this patient, and then we went on to a TMA. But like I said, lifestyle modification is very important. That was another smoker. Here's another incidence where we had to do a partial resection of the 5th metatarsal, and that person did go on to heal. This is another one where you have to really consider the condition of the skin. And here's a good one where the 4th and 5th toes were amputated, but we had to go further because you can see the condition of that particular wound is not good at all. It's very fibrotic and necrotic. And you know, it's hard to believe that people still walk around like this, but it is true. This particular person covered their foot up for days and days. This was actually through a county hospital. And they ended up, of course, there was nothing to do with this leg, but AKA. But I show you that to show you that those people are out there. And there's also people out here who are walking around like this, who are afraid to go to the doctor and afraid to access health care. So in conclusion, of course, it's a case-by-case situation. You have to assess the patient before the amputation as to whether or not they're going to survive after the amputation. You have to do lifestyle modifications. Smoking is one of the biggest culprits in our society. Smoking and obesity, you cannot go in an amputation smoking and being obese and thinking that you're going to survive over the 5-year period, which looks like the gold standard for post-op mortality for amputations. Thank you very much, and this is my little dog.
Dr. Choksi on crossing catheters.
Good morning again. Doesn't move. Thank you. So, dealing with PAD, a lot of interventionalists take a step back when they see a CTO, and they will send the patient to the surgeons, or they will not do anything at all. So let not these total occlusions and blockages stop you from doing things. I think it's a matter of experience. There's no magic to it. Fortunately, over the last decade or so, a lot of catheters have now become available that has made these procedures much more simpler. So just background, 40 to 50% of patients with symptomatic PAD are going to have a CTO. It's the most common in the infrainguinal location. Nearly 50% of SFA presentations will be a CTO. Of course, much more common in critical limb ischemia. There are 4 important things to tackle these things, and that would be for any procedures for the leg, but particularly for CTOs, is patient preparation and positioning, access site management, CTO crossing techniques, and tools. So over the next 10 minutes or so, I'll go over some of the commonly used crossing catheters. But access becomes very important. Access equals success. If you don't have good access, you're not going to get good backup system, you're not going to be able to cross the lesions. And therefore, the standard femoral access, contralateral limb access is okay, but you need to know more. You need to know antegrade access, you need to know radial access, you need to know retrograde from the tibial, posterior tibial, peroneal access. All these things become very important in the management of CTO. I think all of you should learn ultrasound-guided access and access using roadmap. I think there's a thing tomorrow morning for pedal access course. I think all of you should try and attend that. Angiography, one must have selective angiography, read it carefully, study it carefully. Try and study the proximal cap, see it is concave or convex upwards, and accordingly you can choose some devices, look at the reconstitution point, look at the distal cap. So all these things need to be studied first and should be part of the planning process. Just a couple moments I'll spend on wires. This is a busy slide, just tells you that there are a lot of wires available, 14 wires, 18 wires, 35 wires, and one can choose and pick what you want, familiarize yourself with a couple of these wires, and then use that as a workhorse. Most commonly used are the Terumo glide wires. The V18 are also commonly used, and then the command wires, the Confianza wire, the Asahi Fielder, all these can be used for the purpose of crossing CTO. Important to note, support catheters become an important tool to provide support either for the crossing catheters and or the wire. There are also a fair number of crossing catheters, support catheters I should say, available. Terumo has a Navy Cross catheter, which is double-braided stainless steel, tapered tip, comes as an angulated catheter, 4 French design, takes 035 wire. The Cook device is a CXI device. It comes in 2 sizes, 2.6 French, 4 French, comes in multiple lengths, 65, 135, 150, takes an 18 wire and a 35 wire, again, low crossing profile, braided stainless steel, hydrophilic. And then the Trailblazer, which has been there for a long time, the Rubicon. So once again, familiarize yourself with these devices. The CTO crossing tools, there are many. The Wildcat for the larger vessels, KittyCat, the smaller vessels, the Crosser, Power Wire, TruePath, Frontrunner, Viance, and of course the Wildcat also comes with an OCT device called the Ocelot. There was a very nice lunch symposium on that yesterday. I hope that most of you attended that. So just briefly, the Frontrunner catheter utilizes blunt dissection, micro dissection. It comes in 2 lengths, 90 and 140, 6 French teeth compatible. You will need to use a micro catheter, a support catheter, and very low profile. The Crosser uses high-frequency mechanical vibration, comes in 3 different varieties, 14, 18, 2 different varieties, 14 and 18. The 14 also comes in 2 different types. One is for tortuous vessels, one is for straight vessels. Microsheath is necessary. Again, low crossing profile. The Wildcat or the Ocelot is a rotational spinning device, 110 centimeters, 6 French. Support system is necessary. I think it says incorrectly on the slide. 014 wire, 2 millimeter crossing profile. The TruePath is a self-rotating guide wire, 18 French compatible, needs guide support, catheter support, low profile. Viance is a low profile blunt dissection, is equivalent of your crossbars that we use in the coronaries. Support catheter is optional, but I would recommend that you use it. It becomes easier. Again, very low crossing profile, and goes to a 5 French catheter. The entry devices, there are many, at least 4 of them, I should say. Familiarize yourself with at least a couple of them. You don't have to know all. Also, you'll need to know what your hospital provides you with, and then become an expert with that particular device. So this is a Wildcat device that has wedges. The tip spins, and as the tip spins, the wedges deploy. It corks through to the plaque, to the cap, and thereby opens up a channel. In the CONNECT trial, prospective non-randomized trial, 89% success rate. With the Ocelot OCT imaging, very high, 97% success rate. Here's a case of Wildcat through the total occlusion, and once you cross that, put a 014 wire, and then whatever else you need to do, balloon stent, atherectomy, whatever else. This is the Ocelot device that has the OCT on it. It takes a few cases to get familiarized with this device, to know how to read the ultrasound, but once you do that a few times, it becomes quite easy. The Crosser device facilitates central lumen CTO recanalization via atherectomy, high-frequency mechanical vibration, as I said earlier, 14 and 18 compatible. Here's a case of total occlusion on the left side of the screen, to my left, I should say, and then you can see the device on ultrasound there in the slides B and C in the left lower corner, and then there is decanalization of that particular device, of that particular vessel. In the Patriot study, the pivotal study for that, 84% crossing rate. TruePath is another excellent device. It's an 18 wire that goes over a microsheath. The tip is diamond coated, rotates at 13,000 RPM. It breaks through the proximal cap and then facilitates the placement of conventional guide wires once you cross the lesion and advance the microsheath. You can use an 18-compatible microcatheter. In addition to the tactile feel, it also gives you fluoroscopic guidance, and there are 3 lights that indicates where you are. The first green light will tell you that you have that the device is activated. The second green light will tell you that it is engaging the lesion. Once you have red light, then you need to change the angle of the device. Here's the next case of TruePath that crosses CTO. Here's the Viance catheter. I think it's the slide says TruePath is a Viance catheter, is a crossbus equivalent. It's a manual torquing device with minimal forward pressure to probe and penetrate the CTO. It's very useful, successful, easy to use, and if you get into the subintimal space, you can use one of the entry devices to get back into the vessel. In the FAST trial, 66 patients, 84% recanalization rate with Viance and 86 with NTA device. Of course, small numbers, but it is quite successful. Again, you have to get used to the device. This is an example of the Viance device that crossed the total occlusion below the knee. Front runner, it acts like a Pac-Man. The back handle that you see will open and close the jaws. Here's an animation of that. It keeps on plugging along and open up a channel. The success rate is quite low. It's about 56% in CTOs not crossable with conventional guide wire. Then you have the re-entry devices. The commonest one used is the Outback device. You go subintimal, go beyond the blockage. There's a needle that comes with the device. It's incorporated into the device. Manually push the needle, and through that advance a 14 wire. And then you pull the needle back, remove it like a rapid exchange device, and then you can do whatever else is necessary, balloon stent, etc. There's a mark on the device, which is an L-shaped marker. You want the L shape to point towards the lumen. Take an orthogonal view. It should look like a T, sitting right on top of the vessel. Once you have that configuration taken care of, then you know that as the needle comes out, it's going to be in the lumen. The only problem is if beyond the total occlusion there's a calcific area, you may have some difficulty entering the vessel. Here's an example of Outback, getting back into the lumen of the artery. The Pioneer device is similar to Outback, but it's an ultrasound device that will tell you where to go, where to enter the vessel. Again, very useful device. Unfortunately, my institution doesn't have that anymore. But most of the time, if you have a simple catheter, a support catheter like the NaviCross or the CXI catheter, use that with a glide wire, make a tiny loop, and then it'll cross the lesion. So there's, again, nothing magical about this. Just keep doing it, get yourself familiarized with different devices. Importantly, study the angiogram, have plan A, B, C, know what equipment your hospital has on the shelf, and of course, know your limitations. Thank you.
Thank you, Dr. Choksi. We're going to go ahead and go to break. We're going to be closing up the morning session. Please come back. Good Samaritan Hospital, Dr. Amir Matarjame is on standby for their live case, and we're going to go straight to the live case as soon as we're done with our break. Thank you.